Donna's is in 3 parts, as I recall, having read through it. A lot of material, but she's done it in such that when it's on the website and video, it can be some short segments as opposed to a lengthy one. I'm going to just give a heads up here. Donna presents some specific situations. Were you there present? It's written as if you were. These ones that you're personally involved with, Donna?
Me personally, yes.
Okay.
They're all mixed up enough, though, that you shouldn't have to.
Where the family had certain beliefs as to, gee, here's what's going to happen if I didn't do anything or what I do. They're sensitive ones. They may touch nerves in here. We apologize for that. There was some consideration as to how real life we should get in end-of-life decisions or near end-of-life decisions. But I was asked to give everybody that heads up ahead of time. It may be sensitive to if you've been through similar or have something pending with a parent or close friend. But she's a nurse practitioner certified in both primary and palliative care since 2014. Last fall, she joined the palliative medicine group at Ascension Providence Hospitals in Southfield and Novi. She specializes in the symptoms and difficult decisions of advanced illness, and you will hear that definitely in her presentation. When she became an intensive care nurse 20 years ago, she learned how many people can avoid unwanted and painful interventions by taking a little time ahead to explore and document their wishes. Dave's talked about that. Donna's going to further emphasize. After spending 15 years in community health care, including roles as a visiting nurse, educator, primary care provider, palliative nurse practitioner, and program director, she brought those experiences back to the hospital setting. She enjoys teaching people about simple ways to plan ahead and gain control over their own healthcare decisions. Donna, welcome back and thank you. I'm going to cross over.
Thank you. This is new. Okay. Okay, and someone's timing? Because I'll talk forever. Okay, so just wave me down when it's time to stop. I'm so excited to be back with everybody here. I had the pleasure of being invited to speak for the first time last fall, and it was... Is that better? Okay, sorry. So thank you for asking me back. I really enjoyed meeting your group last fall and such really interesting and engaging questions. I think there's a formal Q&A at the end. And so they asked me to present these in 3 unique 10-minute chunks. So maybe if there are questions, would you prefer that people collect their questions and then do maybe a question session after is what I think the format is. Because usually I'm very spontaneous and say just kind of shout things out. So we'll present these in 3 individual scenarios and then do questions at the end, correct?
You can give it an hour here, so
yeah.
It's time. Whenever you want to take questions.
Okay, perfect, thank you. So let's just go ahead and jump right in. This is not medical advice. I'm a medical professional, so I always make sure to tell you that, I'm going to talk about some generic scenarios that are based on real situations, but more of a composite. And so this is to show you what things really look like when they come down to the tough decisions so that you can make better decisions with your own healthcare provider. So I'm not trying to tell you what to do. I'm trying to show you good examples and raise questions and give you tools to explore your own wishes with your own healthcare provider. Also, since this is going out across the country, things I say may pertain to Michigan, but be careful if your own state might be a little different, like we talked about the advanced directives. Some states, they're documented once and good forever, and other states like Michigan, they'll ask you every time. So the first situation we'll talk about is Marlene. Her dilemma was, I came up with the title of Decision Maker Default. Dave did a fantastic job of talking about what's the way that you go about planning ahead and documenting who you want to be your decision maker if you're unable. And this situation talks about someone who hadn't done that and how it can get a little bit tricky. So Marlene's a 59-year-old woman. She was in the ICU. So I work in the hospital setting at a hospital, so we have about 100 to 120 conversations per month with people who are in for everything from a bladder infection and dementia to on the ventilator in the ICU. So Marlene is a 59-year-old woman in the ICU. She had bacterial and viral pneumonia, as well as advanced COPD as a chronic illness underlying all of this. She was on the ventilator that morning that I met her, and she was sleepy, but it was hard for me to tell if she was decisional because she was tired from working hard to breathe. She'd received some medication to help relax her breathing. She got to the hospital because she called 911 herself for shortness of breath, and her ICE in case of emergency phone contact. This is another tip along the lines of put your DNR in the refrigerator, or your advanced directive in the refrigerator. If you don't already have one, EMS or police will check your phone for whatever is entered with the name ICE in case of emergency. So that can often be helpful. So she called herself, but she wasn't able to tell her own emergency contact, so they found it in her phone. And they called her friend Sue. Sue says Marlene and her husband had no children. He had moved out 2 years ago, but she's not really sure about their legal marital status. And that Marlene has 6 siblings, but only is in contact with one of them. So Sue gave Marlene's brother Mark's phone number for us to reach out and try to sort through. Not only was she decisional in the moment, but we knew that we would have some planning ahead to do because things could really become complicated for her in the future. So we'll do show of hands in a minute. True or false? Your spouse is automatically your medical decision maker if you become unable to speak for yourself. How many people think true? Show of hands. Okay. How many people think false? Okay. This one's actually true. Okay, so if you are, one of the questions we ask quite often when we meet people in the hospital, we have a social worker on our team, and she likes to get a little bit of a family tree, and she'll say, are you legally married? Because if you are legally married, then that person is your default decision maker, whether you filled out any forms or not. There are some situations where people are married and have such different goals and values and opinions that you can choose someone else. But if no one else has been chosen, it's automatically your spouse. What if you are separated? Do you think that makes a difference? No. If they're living in another state, that was a question that came up earlier with advanced directive, doesn't matter if they live in a different state. Sometimes this has come up for us. What if they're common law? You guys don't know what common law is? I think I've heard that if you're living together for 7 years, okay. What if you're in the middle of a divorce, which is similar to separated? So the answer is your spouse is automatically your substitute decision maker if you become unable to decide for yourself, whether you're separated, living in different states, or in the middle of a divorce. So this situation was where I learned about common law, but he did not have rights as a decision maker, and he was really not reachable to help. So that was a blessing. If he was not available and the spouse, it becomes even trickier for us. So let's say if there is no spouse, adult, child, or parent, we're doing a little bit of a family tree, and I've got a good slide of who comes next in the hierarchy. So if there's no spouse, no child, or parent, would it be of the 6 siblings that she has? Do you think the oldest sibling has more rights than other siblings as the decision makers? No. Correct. No. All siblings as a group have equal decision-making authority. Yeah, exactly. So majority rules, if we're trying to do group decision maker and people have opposing viewpoints, we try to help walk everybody through what the person's wishes would be and come to consensus, but if we can't, we go with the majority. Okay, so let's see how this sibling dynamic affects Marlene. So these slides are very wordy because some people might not have access to the video, so forgive me for reading a little bit, but she was not alert originally, and then 3 days later, she had finished her antibiotics and was really able to write and express herself clearly on a clipboard for the first time. She's confirmed with us that she's not married, and she thought her older brother, Mark, would be the person in charge. We explained to her that he was not, and now we had to start talking about this is why it's so important to talk about your wishes now, because when you become unable to decide for yourself again, whether it's this hospitalization or down the road, right? We all need to plan ahead. It's the group, unless you decide something different. So as soon as I said that, the last line on my slide is the same reaction you had. Is like, oh my gosh, please no. But that's really how the law goes. So I think this is a good case study. We helped her understand, our job in palliative care, the easiest way to describe it is pre-hospice. And we're focused on symptom management, decision support, helping the people involved make decisions, and then future planning is the best way to describe it. So we say, look, we know these are things you don't really want to talk about, but we're obligated because you're here, you're on the ventilator. We know that because of your underlying lung disease process, you're going to have CO2 that your body can't exhale fully, and that makes people sleepy. So we knew for a fact that we were very likely going to have her become sleepy again, and it was really important to make plans ahead of time while she was alert and could write her wishes. Okay. So at a minimum, she needs a power of attorney for healthcare form, just to name a person to be her substitute. Ideally, the whole form that talks about, all the different medical scenarios would have been great. She did not want to do that. She really, once when I came in to see her, because I would see over a series of days, she writes down, "Oh, doom and gloom here again." So I know, it's hard to talk about this stuff. I said, but at least let's talk about what's important to you. I could document that in her chart and help her brother understand. As long as he understood her wishes and she named him, he could speak for her down the road. So sometimes people misunderstand and they think that someone has dementia or is incapacitated and they want to say, well, you need to make an advanced care plan or you need to do a power of attorney for them. That ship has already sailed. The time that someone can choose a power of attorney for healthcare is only when they are decisional. So this is where Dave's story about his family member that had that sudden brain bleed. Anything could happen to any of us at any time. So now is the time to think ahead. And I appreciate the disclaimer that some of these scenarios might be tough to hear, but I'm really passionate about educating as many people as I can to plan ahead while you have the ability to think and express your wishes. Does not require an attorney. We talked about that. Just 2 witnesses. A lot of times in the hospital, we ask visitors for other families to sign for someone else, because it's really hard if you're in the hospital to find someone that's not a healthcare provider or your own family, right? So it has to be someone who doesn't have a vested interest in your decision. One of our social workers is so good at it, she goes and talks to these other people and ends up convincing them that they need to do theirs and gives them the forms. I mean, it's really, it's not as weird as you would think. At first I thought, I don't know. I mean, I talk about hard things all the time, but I don't know if I could ask a stranger to come sign this form. But she really presents it as, you're not involved in the decision-making process. You're just witnessing that this person signed this form. And so that often kind of diffuses it. And I say, oh, sure, I'm happy to do that. It was mentioned, I want to reinforce, it does not need to be notarized, and you don't need an attorney. And it's only for medical decisions. Sometimes people assume that doing a durable power of attorney for healthcare comes with financial decision-making power, and it does not. I've seen families where they've chosen to split that role. That can be helpful to share the burden, but I've also seen it get very tricky if the person with the purse strings doesn't agree with the person with the medical power. So what I've seen in my background is that it's easier if one person can have both of those roles, but just know that this form alone does not give financial power of attorney. That's something you would handle with whoever's your financial advisor or attorney, okay? And it only takes effect if she's not able to decide for herself, as Dave talked about that. So Marlene does say she wants Mark to sign and be her power of attorney for healthcare. Mark said he couldn't do it. He really wanted to fulfill that role for her, but there were several siblings in that family that Mark was the decision maker for their mother because he was the only one at the bedside. And someone came in and said, you have to decide this now. And he made a decision for comfort care, and his siblings forever, that was part of the rift in the family, was over how things had happened with their mother. And he felt like if she said, I want comfort care, that would put him right back in a role of having to advocate against his siblings, and that would really put him in a very tough spot. Part of what I see our role as the palliative care team is to do is we don't only work with the patient, but that's our primary focus, for them to have autonomy and choice in their wishes. But if we can handle these difficult situations gracefully, I think our job is to help the whole wider circle have a better relationship after someone passes away or after they're in these healthcare crises. So explored with Marlene, who can she trust to uphold her wishes? without pressure from other family members. So she did ask her friend Sue. Sue was really a wonderful friend, knew of the family and their history, but really was removed from the dynamics of that. So she was able to come in and sign the power of attorney for healthcare form. She also documented her wishes that she wanted the ventilator withdrawn if a time-limited trial of a week did not help. We're going to talk a little bit more in the scenario following about what that time-limited trial looks like. So for people on a ventilator, you can say, I don't ever want that under any circumstance. You could say, I would want a ventilator long-term forever, regardless of quality of life, but there's a middle option. And this middle option is what Marlene chose for herself, which said, if I'm not interactive, and if there's nothing that can be done like antibiotics or removing extra fluid that can really fix the situation, she didn't want to continue that way. She wanted comfort care and to have the ventilator removed. She did also, one of the things we talk about is, okay, our goal is to have you off this ventilator, and if that happens, would you ever want a breathing tube again, knowing what you know now? And her choice was no. She didn't feel that she knew where her illness had progressed to with her COPD. It was very end stage. I actually left out of the scenario that she had discovered that she had stage 4 lung cancer while she was in this hospitalization. That made the whole scenario really tricky. But this particular person was dealing with a lot. And knowing what she knew about her cancer and her COPD and her experiences on the ventilator made her able to give really clear instructions to Sue, and her family felt very relieved to know that someone else would be speaking for her, but they all were able to grasp what she was saying. I heard earlier this morning, it's not so much what you hear, it's what you grasp, and I'm going to steal that. I'll give you credit. But that's so true. So her family was able to not only hear what she said, but grasp what that meant for her, and they felt a big relief, especially Mark, that someone else is going to be the one to walk that out when it happened in the future. So what if there is no one documented as power of attorney for healthcare? What is the hierarchy? We talked about spouse being the default. So if there's nothing signed in advance, what does that kind of ladder look like? So it goes automatically in the state of Michigan. Again, check with your state. Spouse is automatic. If there's no spouse, it goes to adult children. If there's an odd number of adult children, it goes by majority. If there's an even number of adult children, we work hard for consensus, but it can be very tricky. Then if there are no adult children, parents, sometimes parents are the ones that are the decision makers, then siblings, and then nieces and nephews. Sometimes we have to go as far as nieces and nephews. Again, if it's an odd number, it's a majority. If it's an even number, it becomes a little more complicated. And so there are sometimes situations where we can't find anyone who's available or willing to serve that role, and the hospital can actually petition for guardianship. And then the medical team makes recommendations to that guardian, who's just a higher decision maker. The court appoints a guardian, and then the medical team shares, what they feel is best and in the best interest of that person with the guardian who fills that role. So the simple solutions that you can do to avoid these dilemmas, I know it's hard to talk and think about these situations, but the easiest thing that you can do is start to think about it first of all. I think the presentation on advanced care planning was wonderful, but some people we meet are not even ready to think about it. Is it Tony? Was that your name?
Yes.
And so I love you. I want your email because you're going to do something to help me. I'm going to have you write your story out or something that you planned so far in advance. But when you shared that your family members, I don't want to talk about it. That's so common. That's so common. Denial is actually so natural for us as human beings, and it can be protective to a point, but it can cause so many problems. This conversation project kit was started by a woman who's a journalist and went through all this with her mother, and it starts very gently and very, very far upstream before it gets to some of the harder discussions. So if you feel like this is intense, this conversation project is a really good place to start. And it's free online. Choose a decision maker and a backup. I know that was a good question raised earlier. So what if my initial choice cannot fulfill their duties? We actually recommend, someone else mentioned that the three of you were advocates, correct? You and your two siblings were advocates. And sometimes that works beautifully. Quite often parents don't want to choose one of their siblings over the others for feeling it's like a show of favoritism. I'll hear that from my patients. So it can work to have all three be equal decision makers, especially since you're blessed with an odd number. That helps. But it's more helpful to the healthcare system as far as trying to reach someone overnight in case of an emergency for a decision if it's in order, if it's in ranked order. So you can do whatever you choose. Maybe shared decision making could work with your family, but even if you will all be discussing as a group and you all agree to act with whatever you agree with as a group, having one person be that primary, secondary, and then third is much cleaner and saves time. And it's complicated for us in the healthcare system if there are three that have shared decision making, and it could mean a delay in starting or stopping care. It just could take a little longer to have those wishes implemented. So it's not wrong if you're all available and accessible and in agreement, but it just can because we would have to talk to all three people. Okay. Got it. So I think that's nice. So the answer was that they weren't shared, but all three of you would agree to be available at any time. So whoever's first reached has the authority, is how you've kind of decided. Whoever is available has full authority.
My husband was more able to be at the hospital during the day and keep an eye on things. My husband was more available at the hospital and have an eye on things. I was at work, but he would call me, the doctor would call me. We worked well together in this case.
So more like in shifts.
Kinda, yeah.
That's interesting. That's creative. I like that. So, okay. And so the rest of the slide is pretty straightforward. It's mostly the thinking about it and the talking about it is the hardest part. Once you've done those two really courageous things, documenting it is very key. I learned this morning that to put it inside the refrigerator in a plastic bag, I knew they looked in the freezer, forgive me, the freezer, not the refrigerator. I would always sometimes tell people to post a single form on the outside, but I never thought of a fire. So the question was raised, what do you do with your form now to make sure EMS can find it? So I like that idea, and I'm going to use that. That's what I learned today, is that not only should it be around your freezer, but inside the plastic bag so that it survives whatever kind of disaster might happen. Okay. So there is, Dave does have some copies of the bigger advanced healthcare form, directed healthcare form today, I believe, and I have a one-page part that I'll talk about in the next video. I have the one-page do not attempt resuscitation form. So we do have some forms for you today at the table in the back, but there are links to all the forms on the slides that I've shared that they'll post on the NCRO website. And then if you're in other states, that AARP free website is a really valuable resource. The gentleman had a question about how do I know if I'm a snowbird, like so many people in Michigan are. If you go to Florida or somewhere else warm in the winter, that's a good resource to start and find out who to verify, what forms to use for which state. Keep your copies handy, make multiple copies. And if you choose no CPR or do not attempt resuscitation, that's where I say to put the copy on your fridge, but now I learned to put it in a plastic bag in your freezer. But they're all trained to go there. Quite often someone would have an emergency at home, like a fall, and need EMS to come help pick them up. But then if there's a crisis while they're there, they would be obligated to start CPR without, and honestly, if you have the one-page form, which I have copies of today, that says don't attempt resuscitation, they can read that quickly in emergency. Sometimes I've heard stories of, because I was in the community for 15 years, where people would say, they came and I gave them my 30-page advance directive and they wouldn't even look at it. They're not gonna, I understand the frustration, but I understand EMS's point of view. So that's where a one-page, if someone is in such a health state that you decide not to attempt resuscitation, then the one-page sheet is really what's most helpful to EMS in a crisis. All right, and this is my thank you slide. I think this is kind of clever. Advanced care planning side effects may reduce pain, suffering, and unwanted interventions. Most people report an increase in comfort, confidence, and a sense of control over their future. So when someone says, oh no, it's doom and gloom, I say, oh, yeah, but after we have these talks, you usually feel much more confident about your choices, and you know what you have control over. And then report any changes and goals to your healthcare provider immediately, because we can all change our mind at any time.
The question is, what takes priority, the patient advocate or the advance directive in the hospital or when the EMS comes?
So an advance directive contains a lot of explanations about what kind of care someone would and would not want, but it's not usually totally comprehensive of every possible situation. And it sometimes has language that says things like no extreme measures or all appropriate medical care. So the person, as the decision maker, could find themselves in a situation that either isn't covered by the advance directive or maybe isn't appropriate anymore. The next video actually talks about a situation where just that thing happened. The person made their advance directive a long time before and it was no longer appropriate. So the person with the authority within context, they can't go off the rails and do something that are completely outside of the context of the person's wishes. But it's a very good question, and it's part of what's in the next scenario. Okay. So I do take questions if there's something you think about. After the last session, we did get a few questions and shared them with Chuck, and I think he shared them all with you. So if something comes to mind after we're talking, I enjoy questions because that way I can use what we discussed for other people that might have the same question.